Assalamu alaikum, the long clinical consultation day. First scenario, Miss Julia Brown. She is 30 years old, came with a history of fatigue for the last 6 months. Please take history, examine the patient, address her concerns. Here you go.
Hello, I am Dr. Mohammed. I am one of the doctors here today. I need to confirm, Miss Julia, 30-year-old with me.
Yes, I am Julia, doctor.
We are here, Ms. Julia, to discuss some health issue for you. Well, we'll take some history. I do some examination. All will be confidential if you don't mind, okay?
That's fine.
Can you tell me, please, in your word, what brought you today to the clinic?
Yes, doctor, actually, I have been feeling more tired and fatigued for the last few months. So that's why I'm a little bit concerned about that. That's why I did so. And that's why I requested my GP to send me to you so that I could have further evaluation.
Okay, I am sorry for that. But can you tell me, please, what you mean by fatigue? It is weakness or you feel easy fatigability, your energy is low?
I feel tired most of the time. So it's a kind of tiredness, and whatever I do, I feel very fatigued, and it seems that I don't want to continue with those activities, and just kind of more, you can say it's kind of a tiredness, and yeah.
Okay. Okay, sorry for that, Miss Julia. Does it start suddenly, few months back, or it started gradually?
It was there previously as well, but I have noticed that in the last 6 months, it has been gradually getting worse. So I'm finding it quite difficult to manage currently.
Okay, sorry for that. Does it related to specific time of the day? You notice it by the evening or any time increasing?
I mean, Most of the time, I feel fatigue. Generally, you can say it is almost all the time. And if I do some kind of an activity, obviously that makes it further worse.
Okay. Anything make it better, like become more rest?
Not really. You can say, but not much. It's more or less the same.
Okay, okay, Miss Julia. Do you feel any change in your weight?
Yes, I have noticed that I have been gaining a lot of weight as well.
How much kilo if you measure it?
Well, I haven't measured, but I'm pretty sure that it's quite significant
Okay.
because my
Does
my clothes seem that they are not fitting me properly now. They feel quite tight.
Okay. Does it increase in a specific area or body, like in between in back in between your shoulder or your hand or feet?
I feel that it's more kind of a generalized kind of a weight gain.
Any lump or bump in body or swellings?
No, I haven't noticed any swelling as such.
Any fever, increase in your body temperature or sweating?
No, I haven't noticed anything like that.
Okay. Any joint pain or swelling?
Yeah, I feel pain in most of my body. So it's not specific to joints only, so it's kind of a generalized pain all over.
Okay. So your hand, no problem in your hand on specific lateral part of your hand?
No.
Okay. Okay, Julia. Any back pain?
I said that I generally feel pain all over.
Okay. Okay. You feel any problem during sleeping, snoring, or anyone notice that?
Yes, I have been snoring a lot, so I think that my sleep recently I found that it's not very good. So yeah.
You feel sleepy all over the day or feeling unrefreshing at morning?
Yes. Yes, I do. Yeah.
Okay. Do you feel any change in your skin, like rashes or acne in your face, or
Uh, I think that my skin seems a little bit more rough, if that makes sense. Yeah.
do you have any weather preferences, especially to cold intolerance to cold weather?
Yeah, I prefer staying in a warm weather, and obviously I prefer staying in the sun.
Okay. What about your bowel work? It's more hard nowadays.
Yeah, I mean, I have issues with my bowels for quite some time, but it seems that it's getting worse as well. So it's more kind of a hard motions.
Okay, sorry for that, Miss Julia. What about your period, Miss Julia? How it is nowadays?
No, I mean, they're quite erratic. So basically, I think that I have been going through periods where I feel that they are very heavy as well.
Okay, sorry for that, Miss Julia. Any previous pregnancy before?
No, I mean, I have no previous pregnancy, no,
Okay, so no previous miscarriage, any pregnancy, right?
no miscarriages as well.
Okay, any birth pill you are taking?
Sorry?
Birth control pill.
No, I'm not on any birth control. No,
You are married, Miss Julia?
no, I'm not married, but I have a partner.
Okay, okay. Miss Nadia, what about any heart racing or feeling the heart any
No, I haven't noticed any racing of my heart.
shortness of breath or cough?
I, I mean, as I said that, I mean, I do feel kind of a shortness of breath on exertion, but it's more to do with the fatigue, I think. Yeah.
Yes, okay, sorry for that. Anyone notice you are more pale nowadays?
Yes, I think that even some of my family members, they told that I look quite pale now.
Any bleeding from anywhere body or this of body?
I mean,
Coughing
as I said
blood?
that, yeah, yeah, generally, as I said that my periods are quite heavy, and this is a
Okay.
problem which have been going on for about a year or so, and I feel that it's getting progressively worse.
Sorry for that, Miss Julia. Any time you have more dizzy or feeling fainting,
No, I haven't noticed any dizziness as such.
even if you are standing from lying to stand up?
No, I haven't noticed any dizziness.
Okay. Any past medical history? If not, I need to know, like diabetes, hypertension.
No, I don't have any diabetes or hypertension in the past. No.
Any family history? If not, like same condition.
Uh, I'm not sure about the same condition, but my I have a family history of diabetes in my parents, and also they have hypertension as well.
Okay, sorry for that. What about your water work? Increasing nowadays?
Uh, I mean, I haven't noticed anything like that, so they seem pretty much the same.
No change in color or frothy or anything?
No, no,
Any, any allergies, Miss Julia?
no, I don't have any allergies.
Any travel history soon?
No, I haven't. I mean, I haven't traveled outside of the country.
Okay. Any, sorry for this question, any taking part drugs?
No, I do.
Any,
I do. I do drink alcohol, but otherwise, no, nothing. No other drugs.
how much alcohol, Miss Julia?
I mean, it varies. Obviously, it depends more on the weekend. But I think that I may be drinking a little bit more, and I am definitely. I mean, because of my current health issues, so I feel a little low. So that's why I do drink. I feel that I'm currently in the last few months. I'm out of the limits.
Okay. We are advising you to be moderated to help us to managing your condition. Okay.
Mhm. Yeah,
Any
I'll
smoking?
try. No, no.
Okay. What about your job?
Well, I'm I'm working in NHS as a nurse.
Okay. How does this affect your job?
I mean, it's actually nowadays I'm struggling to be honest. It's very difficult, especially working and when I'm having a long duty for say 12 hours or even. So I think that fatigue is definitely something which is bothering me a lot.
We will help you, give you some sick leave until we fix your problem. Okay.
Sure.
Okay. Julia, any time last few months you have any sore throat or increasing body temperature at this time?
Uh, Not really. No,
Okay. No swelling in front of your neck, right?
I haven't noticed any swelling.
Okay. Okay, Julia. Uh, any headache?
Yes, I do get a headache actually. Yeah.
Okay. Any feeling in pins or needles?
And yeah, I do get some. kind of in the needle occasionally. But I think that's something which have been going on for some time. But I do get it mainly in my feet.
Mainly in your feet. Okay.
Yeah.
Can I examine, please?
Yes, please.
Okay. Generally, patient body mass index, how much?
She has a BMI of 30.
30. Okay, I will see her hand. Any
Okay,
swelling
just
to the
sorry.
right?
So the blood pressure is 150 over 100. The pulse rate is 56, and it is normal. Yeah.
Okay. Any postural hypotension during standing, from
No postural hypertension.
dryness of the palm of the hand and sweating?
Yeah, the hands look dry. Yeah.
Okay, I will ask to make her standing without support. What for proximal myopathy?
No signs of proximal myopathy.
Pallor or jaundice?
Yeah, there is pallor.
Okay, the eyebrow loss of the lateral part.
No, but the hairs are quite sparse, but otherwise, yeah, okay.
Okay, the large tongue.
The tongue seems to be a little enlarged as well.
Okay, I will give her some water to test any swelling in front of the neck.
Mm-hmm. All right.
There is swelling.
There is no obvious swelling as such.
Okay. I will test it rapidly also by some water to see any nodules there.
Mm-hmm.
Any nodules?
No,
Okay, I will test lymph nodes. Any lymph nodes?
no lymph nodes.
Okay, I will check heart. S1, S2. Any gallop?
Heart sounds are okay, and there is no gallop.
Basal crackles in the posterior lung.
No crackles in the lungs.
Okay, I will examine. I will ask her for stand, and I will check ankle reflex delayed.
Yeah, reflexes
Okay.
are delayed. Yeah.
Any lower limb edema or rashes?
There is bilateral edema, and it is non-pitting.
I will ask for tap to check neck circumference and abdominal circumference. How much?
Mhm. So the neck collar size is around 17 inches, which I think I don't know about. It's around, you can say 38 to 40 centimeters.
Okay. Do you drive, Miss Julia?
I do drive, yeah.
Okay, please, I advise you to hold the driving until we fix this problem, okay?
Okay, so what's the issue with driving? I mean, because I only have fatigue.
Yes, yes, Miss Julia, for now, what's your concern? So then I will
Well,
answer you about
yeah,
the driving.
yeah. So I think, doctor, I have a lot of concerns. So I just wanted to ask you first that what exactly is going on?
Yes. Yes, Ms. I appreciate your concern. After taking history and examination, we have a condition called hypothyroid with complicated by obstructive sleep apnea. This is
Mm-hmm.
there is don't bother yourself by the term. We have under activity of one of the gland in front of your neck responsible for some protein that is helping and
2 minutes left.
having many functional body relating to your energy, and this
Mm-hmm.
also related to your heavy periods, and you become more pallor. Your mostly your blood count dropping and causing this headache and become more fatigue. And you asked me about the driving. We are afraid sometime when they have more weight and there is some problem during sleep. We are afraid that you may be sleepy during the driving. Okay.
Mm-hmm. Okay.
Is it
Right.
clear, Miss, Julia? Any other concern?
Yeah, I think that I'm definitely a little bit concerned because I'm working and I'm afraid of losing my job as well because as I said that my work performance is not very good. So this is another thing which is bothering me a lot.
I appreciate your concern, Ms. Julia. We are here to support you. We have social and occupational team here. We can give you some medical report and occupational health will help in such issue until we fix your problem. Okay.
Mhm. And this is all treatable.
We will share our endocrine doctor. We can replace this medication called L-thyroxine. It will help too much in your condition, and with our dietitian and our gland doctor also will help to your weight come back, and this will be mostly controllable up to be near normal life.
Right, right. Okay. All right, doc. Thank you.
Okay.
Okay, time
Any
is
other
up. A
concern?
question? You want to add any concern, Dr. Ihtisham?
No, I'm done. So I think that's
Okay,
it.
you can ask him now the questions.
All
Ask them
right.
your
Okay.
question.
All right. Sorry, I forgot the name of the candidate. Sorry.
Dr.
Yeah, Dr.
Muhammad.
Muhammad Abdul.
No, okay, sorry. Dr. Muhammad, okay. So if you can just briefly present your case and your differential diagnosis based on the history and your examination.
Okay. We have a female, 30 years old, Julia Rebels, I'm complaining of 6 months gradual onset progressive course of fatigue. By taking history, the positive data, there is a generalized increase of her weight, and there is many positive history of uh, concerning for hypothyroid, like
Mm-hmm.
hard stool, like increased fatigability, bradycardia, in the examination. We have also heavy periods. All
Mm-hmm.
this we have also delayed ankle reflex in the examination, and the complicated by mostly obstructive sleep apnea. Patient has snoring at night and unrefreshed sleep at morning.
Mm-hmm.
This is the complication. My differential diagnosis: uh, primary atrophic uh, hypothyroid complicated by obstructive sleep apnea. I bought other differential, take but against that, no throat pain, respiratory pressure. Soon, I bought also postpartum thyroiditis, but patient no pregnancy, no history of
Mm-hmm.
pregnancy.
Right. So your first diagnosis is autoimmune thyroid. I mean, Hashimoto's. You're saying, right?
I need to confirm by I asked about
Okay. But
I asked.
okay. But you're saying autoimmune. Basically, that's your first, and is
Yes,
the second.
I bought primary and autoimmune. This is my first diagnosis,
Right.
but
And
I need to
what's the
confirm
second?
by doing
Yes.
hemoglobin
All right.
A1C and doing vitamin B liver for pernicious anemia
Mm-hmm.
because the history not.
Right. Okay. And what's the other differential diagnosis you're saying?
I told Van thyroiditis, but against that, no fever, no throat
Mm-hmm.
pain.
Okay. Okay.
Also, we have postpartum thyroiditis, hypothyroid, but also no history of pregnancy.
All right. Okay. Right. How you will investigate this lady?
I will apart from basic investigation, CBC for anemia to see how much hemoglobin, and
Mm-hmm.
ASRB for inflammatory marker to allow the decurvan. I will send for full thyroid panel, TSH 334. I will send for ultrasound thyroid and thyroid uptake and thyroid antibodies, antithyroglobulin and antithyroperoxidase antibodies. For this is to confirm my diagnosis, to assess the complication. For OSA, I will ask for polysomnography
Mm-hmm.
to confirm apnea and hypopnea index. Uh, for heart, I will send the ECG and the echo for rule out
Mm-hmm.
core pulmonary or pulmonary hypertension.
Mm-hmm.
By history, the patient exclude any carpal tunnel syndrome sign. So,
Mm. All right. Okay. How you're going to manage her?
by multidisciplinary approach, including endocrinologist and pulmonologist. I will start L-thyroxine according the endocrinologist advice, and I will education and counseling the patient about the disease, and I asked her for hold driving until we fix this problem. Regarding and follow up thyroid function every 6 weeks until become the normal level. Regarding the OSA, will refer for dietitian to help in weight reduction. And if after confirming if there is OSA, we will, according the pulmonologist, if need device or CPAP or some surgical maxillofacial.
Right, right. Anything else in terms of the management? Any other thing you want to do in terms of the management of this lady?
Yes, I am thinking. I will search for. I will send also for hemoglobin A1C and lipid profile and other autoimmune screen, uh,
Mhm.
uh, uh, vitamin B level, and anti-celiac antibodies.
Right, right, right. Okay. All right. Okay.
You're done?
Right. Yeah, I think that I'm done for now.
Yeah,
Yeah, I think.
6 minutes already now. You can
Yeah.
start again.
All right. Okay. Right. Okay. I think that uh, first of all, I think that obviously you were able to reach the diagnosis pretty early in the case. I think that once you were able to reach the diagnosis, uh, now regarding the history, I think that you didn't, I mean, ask few questions. Obviously, you asked a lot because with the endocrine history at time, it's a lot of thing because it is kind of a multi-system involvement. So it's difficult. But I think just as a screening question, uh, you didn't explore that what kind of problem she's getting with the fatigue at work. So, I mean, because she might have told you that she keep on sleeping at work at time in the afternoon, so that you just need to explore the symptoms more, like what happened exactly, just to find out that what exactly, because she, one of the concerns she mentioned was that she's worried about losing a job. So you need to find out that what exactly is the problem at job, and what's concerning. So she was worried that she kept on sleeping at work and being warned by the manager that this is something which is not working. So I think that's something you maybe need to go more in and discuss. Then you need to, I think that regarding uh, sleep apnea, I think that you ask a lot of things, but just to, I mean, just uh, uh, for everyone's understanding. So you know about those uh, stop bank questionnaires, which is basically we do to screen for the obstructive sleep apnea, which stands for the snoring and tiredness, or and have anyone observed that you stop breathing your sleep, high blood pressure, and also in the management. And I think that the other thing is the BMI, age, neck circumference, and the gender. So these are the 8 questionnaire, and then we can see that what exactly is the results of that. The other thing you, in terms of the management, I think otherwise everything was okay. I think that you didn't took notice of the blood pressure. So blood pressure was 150 over 100 in a 30 years old female. So it was high for her age, and it could just be due to either hypo, and even if you have obstructive sleep apnea, that could also be causing an increase in the blood pressure as well. So that's something I think that you need to highlight and mention to the patient. One thing I feel that you didn't go into a little bit detail, and I would rather go in further detail regarding that, was a headache. The patient mentioned that he has headache, so you didn't explore the headache, that what exactly is the timing of the headache, where exactly you're feeling the pain, what kind of headache is it, and whether it is because, as I said, that headache may just be due to hypertension, it may just be due to the obstructive sleep apnea. So I think it was an important symptom, and then obviously the history was not going with that, but you know that people who have something like an acromegaly, they could also have a headache, and also they could have other symptoms as well. So that's something which, as a part of differential, although there was no other feature to suggest that, but I think that you needed to explore the headache a little bit more. And in this case, I would consider doing an examination in terms of the eye examination as well, just to make sure that there is nothing, and offer fundoscopy. Obviously, you don't need to do the fundoscopy, but you need to offer the fundoscopy at the end to tell the examiner that I would also like to do the fundoscopic examination as well. Your differential was okay. I think you can add. That's what I feel. I think that it's open for the house to decide. But I think that the other thing, because differential is that something which you think is most likely, and the less likely possibilities, obviously, in which none of the things fit in properly. So I think that one of the differential could potentially be considering considering the problem with menorrhagia, and also having weight changes and skin changes and all these things. The one differential which could potentially put in as in a female, young female, could be a polycystic ovarian disease. You have rightly put in an autoimmune polyglandular syndrome. I think that's something obviously I would like to rule out in this patient, because there is a possibility that other than hypothyroidism, she might be having an underlying autoimmune pernicious anemia as well. So that's something you mentioned. I think that's right. Apart from that, the other thing, because you have found out the signs, so that seems less likely, but you can put in as something like a chronic fatigue syndrome. One or two symptoms I think that you should have asked a little bit more. You didn't ask about any mood changes. And if you would have asked, the patient is likely to told you that there is some issue with the mood, because these patients, they do get depressed. So the depression could just be part of the illness, or it could just be a part of the hypothyroidism as well, or that could be something related to a fear of losing the job as well. So I think that's something. Regarding driving, you advise on driving, but you didn't ask if she's having any trouble with driving. She might have told you that once in a while, or maybe once she slept while driving. So I think that you advise in a proper way, but you need to explore that whether she had any problem in driving in the past. So I think that will definitely, I mean, if she would have told you that I slept once while I was driving on a motorway, so in that case, you need to tell her to stop driving, and also to inform the DVLA, because this is something which could potentially lead to serious issues. So yeah, I think these are the things I feel that you should have done a little. Otherwise, I think that you did very well. And you mentioned to the patient about the MDT approach. There were a few jargons which I have seen. Something initially, I think once you said endocrinology doctor. So I think, and then the second time I think you realized that it was to mention as a gland doctor. So I think that was that. So it's better that if you just speak in the patient language, and just avoid these jargons, because that definitely give you negative marks in the exam. So yeah, I think overall it was very good. I think the one investigation which I think that was related to that, which you should have mentioned, is the arterial blood gases. So I think this is something, generally, if you're suspecting an obstructive sleep apnea, so I think you need to look for any CO2 retention, because most of the symptoms in these patients are generally due to the CO2 retention, the fatigue part, and the early morning headaches as well. So these are generally related to the CO2 retention. So that's something obviously as a part of investigation you should consider. But overall, well done. I think that these are my comments. And yeah, over to
Okay.
you, Dr. Basim.
Okay, thank you, Dr. Hisham. Good case. But I want to ask you, Dr. Hisham, before commenting. So, what is the underlying cause? What is the pathology? Is it
Yeah.
primary or secondary hypothyroidism?
Yeah, I think that in this lady, it was a primary hypothyroidism, which was undiagnosed for few, because she had symptoms for few years and then progressively getting worse. And then secondarily, she developed an obstructive sleep apnea. So hypothyroidism could be in a young female. It could just be due to autoimmune disease, autoimmune like a Hashimoto's thyroiditis. So that could be. So it was basically a primary hypothyroidism with obstructive sleep apnea.
And what the cause of pallor or anemia in this scenario?
Yeah. So anemia was multifactorial. She was having amenorrhea. Oh, sorry, not amenorrhea, menorrhagia. So she was
Yeah,
losing a lot. So this was one. The second thing was the association with autoimmune pernicious anemia. So that's something which I think Dr. Mohammed mentioned as well. So need to rule out a possibility of a kind of a polyglandular just to see if there is a autoimmune hypothyroid with autoimmune B12 deficiency or pernicious anemia as well. That could also explain the anemia. Yeah.
perfect. Hypothyroidism itself can cause anemia.
Oh,
What type
yeah,
of
yeah.
anemia?
Hypothyroidism can also cause, generally, it's something which is associated with the macrocytic anemia.
Yes, exactly.
Yeah.
Yes, you're right. So I think yeah, it was a classical case of hypothyroidism, differential as a young patient, female, Hashimoto on the top of them. I was
Yeah.
thinking it might be a tricky case, but it went smoothly with no other underlying pathology apart from the autoimmune. The complication and the association here was picked up by Dr. Muhammad, the OSA, obstructive sleep apnea, and the other manifestation of hypothyroidism. You have to confirm all of them while taking history or to do the examination on all parts of the body might be affected. In brackets, the hand, in the hand, I mean, you will have dry hand, you will have also loss of hair, and sometimes the pulse will be brady. This is peripherally. Apart from that, in the face, you can find loss of outer third of the eyebrows, as Dr. Muhammad mentioned. Yeah, the proximal myopathy. Don't forget before moving to the face. Proximal myopathy, it can be there. The other finding in the face will be, as I mentioned, the eyebrows or even alopecia areata. Sometimes patient will have other autoimmune like loss of hair in the scalp. Apart from that, the neck itself, you have to examine the thyroid as full examination. Even no goiter, I mean no swelling, you have to do the inspection, palpation, percussion, auscultation by offering a cup of water. Can you drink? Inspection, then palpation, then the percussion for retrosternal extension, then the auscultation for buoy, and the lymph node. Don't forget to offer the examination in the cervical and the supraclavicular. The heart examination, you might have cardiac output failure. Yeah, you might have crackles if the patient is, as mentioned in this scenario, heart failure, or if there is significant affection in the heart, cardiomyopathy, for example, dyslipidemia. I forgot to mention the obstructive sleep apnea examination, the mouth, large tongue, uh, the size of the neck, or the circumstance of the circumference of the neck, as in this scenario, more than 17 inch. And then the other examination in the fat distribution all over the body, tummy and chest and the neck. Then the leg examination for edema, and don't forget the delayed reflexes. So these are the parts you have to examine. What about the history taking? You have to know about the constipation. Also, you have to rule out the compression signs, as we discussed last week. Compression signs of goiter. Do you have any a hoarse of voice, or difficulty of swallowing, or difficult or short of breath? Okay. Apart from that, the history of GI constipation, the female history for periods. And remember, Dr. Muhammad, while you are talking to the patient or the surrogate, you can talk in non-jargon way. So you can say you have or patient is having a period or heavy period to the patient. While talking to examiner, you will say terms, right? Medical terms. So you will say menorrhagia, okay? Because you mentioned heavy period to the examiner. Anyway, it's sometimes it could be accepted, but try to train how to talk to the examiner and how to talk to the surrogate. As Dr. Ihtisham mentioned also here, The endocrine doctor, you have to say it to the examiner, while gland doctor, you will mention to the patient or the surrogate. The I think yes, the trick in any thyroid. This is the take-home message of this scenario. If you have a thyroid case, the trick in the thyroid case, you have to know what are the underlying pathology first of all, and the association or complication. So don't think the case will come as straightforward. As in this scenario, there is a trick. What is the trick here? It was about the OSA, sleep apnea. Okay, and a lot of complication and association with OSA, sleeping, driving, all of them you have to raise to the patient and to the examiner. Plus, even the impotence, the OSA also cause impotence. You have to raise all these points with the patient as a questions or to the examiner as advice. What other association you might have in the thyroid as a trick? As Dr. Hisham mentioned, it can be part of polyglandular syndrome. So you will have Addison and diabetes or diabetes. Addison is a must, diabetes could be there. What other association? You might have a case of the underlying pathology, I mean. It might be a case of iron deficiency or iodine deficiency. So it will be tricky more. If you ask who else in the family has the same problem, you can find the whole family, even the whole village or the whole area having the same issue. Okay, so it will be as iodine deficiency. The other causes, if there is history of infection, previous infection recently, sore throat or whatever, it will be as subacute thyroiditis. So you have to know why this patient is having hypothyroidism. The last one, maybe not the last, we have a lot of causes. The pregnancy, any pregnancy or delivery recently, yes, the patient will tell you yes. Did you notice these symptoms started after the pregnancy? Yes, it would be a case of postpartum thyroiditis. Or it will be something hidden, any medication you are taking. Yes, I'm taking lithium, I'm taking amiodarone, could be the cause of the thyroid or drug induced. So it's a tricky case. It's not only the issue you have to find the manifestation of thyroid. No, you have to know what is the underlying pathology and what are the association or complication. Okay. Here also you can raise the issue of pallor related to, as Dr. Muhammad said, related to pernicious anemia as association, or you can say it's related to macrocytic, as we mentioned, related to the hypothyroidism itself, or it could be as what else can be as anemia in this scenario we mentioned the hypothyroidism as macrocytic anemia, pernicious anemia, maybe.
Menorrhagia in Italy.
Yes, menorrhagia
Iron
itself.
deficiency due to
Iron
menorrhagia.
deficiency, exactly.
Yeah.
So these are the all types of anemia with thyroid or hypothyroidism particularly. Be ready to know all this complication or association. The driving, you have to raise it by yourself. Don't wait the patient to tell you. My special advice to Dr. Muhammad, the system review. You ask about the headache at the end of the discussion. That's why you didn't or you couldn't analyze it.
Yes,
I
yes,
believe.
Dr. Bassem. It missed from me
Mhm.
because of time خلاص بس so I
Yeah, my advice always, if you follow the package or the system, the organized way of question, you will cover all the things. For example, when you ask here about the weight gain, it's good question. By the way, the fatigue always it comes in this way, either with weight gain or with weight loss. So this is the main classification of or the main approach. Is it with weight loss or weight gain? Weight loss, you will go for with anemia, infection, cancer, or autoimmune connective tissue disease. Weight gain, you will go with the endocrine, rheumatological, as in our scenario today, acromegaly, mainly. So most of them increase weight due to endocrine issue. Cushing, polycystic ovarian. Our case today, hypothyroidism. Okay, so these are the possible case of, or the diagnosis if you have weight gain. So the most important question, as Dr. Muhammad did, ask about weight gain. Okay, let's go to the next system or the next question. The appetite and the loss of appetite and the lumps or bumps, night body temperature or fever, and lastly, any fever, lumps or bumps or lumps in front of your neck. You can ask about dizziness to rule out Addisonian association. You can ask about itchiness if you have liver or hepatic involvement. It could be all of them as constitutional symptoms. Then, for me, I believe I should ask about past medical history. If I have diabetes in this scenario, I will think about polyglandular syndrome. Okay, any surgery. Whenever I start asking past medical question, I would ask about past surgery, past allergy, past procedure, admission to hospital, any over-counter medication, any medication. Show me your medication list. Then I will be finishing all the past medical history. Now the time to start systemic review. Even I will know that there is possible manifestation of hypothyroidism. I could ask them, all of them, during systemic review. How I could ask, starting from the head CNS, any headache. Yes, there is headache, going with OSA. Any vision issue. Sometimes it might be there if you have anything related, but if not, you can skip to the next peripheral neuropathy related. So any weakness or any numbness in your hands or tingling. If you want to ask more, you can ask the hearing, the balance, and so on. Next, the goiter itself, the endocrine question. So any intolerance in weather, I want to confirm this is hypothyroid. Yes, the patient will say, yes, I have intolerance to cold. I prefer always to be in warm weather. What other question you want to ask here? You can ask about diabetes. Do you feel thirsty? Are you having feeling of hunger? Whatever the question for diabetes, you can add here with the question of endocrine. The next, difficult swallowing, any difficult swallowing. I'm talking about still the neck. Any difficult swallowing or mouth sores? No. I will ask about chest pain, awareness of heartbeat. You feel your heartbeat are slow, particularly in this scenario? No. Then the chest, any short of breath, any cough, any change of your voice, because here you can suspect the recurrent laryngeal nerve compression, and the patient will have hoarseness of voice. Then the GI question, any change of your bowel habit, any tummy pain, any tummy distension. Then the female history, any change of your period, any pregnancy recently, any birth control pills, and the next genitourinary, any change of your water work. Lastly, the musculoskeletal, any joint pain, any skin rash, any dryness of your skin. You can manipulate the question regarding, or it might be related to the case. According to the case, you can manipulate your question. But if you do the systemic review from up down, you will not forget any of them. Whenever you have any positive finding, analyze them more. You have headache? Let me know more about it. I have some difficult swallowing. Let me know more about it. Difficulty of breathing. Tell me more about it, and so on. By this way, you will not forget any of them. Then family history, travel history, and HIV questions. Even here, you can ask about the intimacy could be affected. Lastly, do you smoke? Do you drink alcohol? Do you drive? And what's your job? The impact on the job. This is as again, and again, what I prefer to do. Otherwise, you will look to the examiner you are asking from here and there. If you ask about the headache at the end and some in between, you have asked about also questions, not in a systematic way, they might comment on that. It depends on the examiner. Some examiners they can accept it, others will not. But I'm not sure if they will minus or no. Okay. In general, as performance, the examination, the history, everything was okay, apart from the comments I mentioned. Any question, Dr. Ihtisham or Dr. Muhammad?
My request from Dr. Hisham only during the exercising, and this is the true in the real exam. The
Mm-hmm.
answer to interrogate must be short and targeted, and you can hide, no problem. You can do some tricky. But
Mm-hmm.
during this exercise, I feel I am waiting too much to fulfill my approach here. Okay.
Yes, okay. Other thing,
Dr. Basim, you are wanted for
yes,
us
yes.
what opinion?
Yes, my opinion, the online always waste the time because you are waiting for the answer. In the real exam or face-to-face practice, you will save a lot of time. So don't worry about this. But believe me, in the exam, the patient or the surrogate will be trained. He will give you the short and direct answer. And sometimes they have clue, they can even explore it to show you that this case might be related to this clue. Okay? Don't worry about that. It depends. And the because of the time lag and the internet and the Zoom meeting, it takes time. But in the exam, if you went systematically, you will have good time at the end to examine and even the address the concern. Clear?
Okay.
But for training, as a training point of view, yes, please try to answer short to help the other candidate to know. If you want to hide, okay, skip this part, don't tell him. But when he asks, answer it directly, as helping each other. But also to be more hard, it's good. Why? Because in the exam you don't know what the situation is there. That the surrogate might be also hiding something, and you will not get it unless you ask about it.
Yeah,
Yes.
sorry, one thing I think I just wanted to ask one more
Mhm.
thing. I
Yeah.
agree that, yeah, some of the answers maybe it was taking a little bit more. So obviously next time I will be. The issue is that at time, I mean, we need to be mindful of that as well. Sometime in centers out of the UK. So what happened is that you are taking a history from a surrogate or someone else who has been
Mhm.
given the history question, and then you're examining. So it takes a little bit more time. So you just need
Yes.
to be prepared for that because anything can come, like for example if you're appearing in Middle East, so a lot of time there will be history from someone, like someone from the nursing team or someone who is not the proper patient, and they will be telling you the history, and then you will be examining. So when you're taking a history directly from the patient, the advantage is that generally when the patient is speaking, when you are observing the patient while you are taking a history, you pick up clues. So that is something which obviously is a disadvantage when you are taking a history from some surrogate, because you're not getting those clues. Because if there's a problem with the speech, if there is something which is obvious just on the inspection, these are the kind of thing which you might miss initially because you're not taking the history directly from the patient, and that actually take maybe another 1 or 2 minutes from. And obviously it's an exam which is a lot of it is to do with the time management. So in that scenario, you're likely to lose maybe in 1 minute, and that could prove costly as well. So I understand what you're saying, and I think that because I have been doing it, I've just done it for after quite some time. So next time I'll be a little bit more brief, but you need to be prepared for such scenarios as well, that at
Yeah.
time in these cases that can happen as well. Yeah, thank you.
Yes, I can add also to your comment, Dr. Hisham. It's like you are playing a game in medium level or in the easy level or hard level. Whenever you have hard surrogate in the training practice session, you will be more professional and fast in the exam. Okay, so it's a matter of how to manage the time even with the hard surrogate. Do everything in your practice in the sessions. Why? To be ready in the exam. You don't know what the situation will be there. You don't know if the patient will be fast answering or he will be slow answering. He will delay you, he will hide some points. So the best way is to face such issues in the training session. Okay, but to make the things easy for us or for everyone, yeah, you can tell shortly and briefly, but you can accept or not according to the level of your gaming. Okay. Okay, Dr. Ihtisham, before moving to the next scenario, your scenario, second scenario, 48 years old female, Miss Nadia Farouk. with a complaint of vomiting. Please take a history, examine, and address her concern. 2 minutes, then we'll start. I will read the comment quickly. And yes, I think Dr. Hida started the differential Addison, but I could say Addison will patient will have loss of weight, not gaining weight, Dr. Hida. Maybe you put the differential before this point, but it's still one of the fatigue presentation. You're right. Hypoglycemia, anemia, obstructive sleep apnea, myasthenia gravis, hypothyroidism. Perfect. You catch it at the end. Dr. Lamar, hypothyroidism, obstructive sleep apnea, acromegaly, Cushing, polycystic ovarian syndrome. Dr. Ala or Ala, with regard to driving advice, is it normal to hold driving in obstructive sleep apnea or the case will be narcolepsy? Yes, you have to stop driving. Anything might harm or might affect the patient's safety, you have to do. Don't wait. You can stop driving temporarily, then address it later on, after the diagnosis, after the treatment, after whatever. But don't let him drive and he has any risk or he is at risk to have any accident. Okay? It's a dangerous point. Dr. Marwa, look simple, but this truly a deceptive case. I think the danger of classic cases is that exactly the examiners will be very tough in the term of marking. One tiny mistake might not be forgiven as in rare cases. Exactly. Well done, Dr. Muhammad, and me thank Dr. Hisham. Yes, I agree with this comment totally. If you have spot diagnosis case, no, you have to know that there is a trick. You have to catch the trick in this, why this case is straightforward. Okay. So either you have a complication or association or the underlying cause, something hidden. Patient might take medication, and if you couldn't know the medication list or see the medication list, you might miss the case. You are thinking it's classic case of thyroid, for example, in this scenario, a classic case of thyroid. Then, while seeing the medication, if you ask, for example, and necessarily ask about medication list, you found, for example, amiodarone. Oh my God! So the case will be deviate totally to another diagnosis, right? So please don't underestimate your case. You have to know what is or what are the trick. If there is something straightforward, either you will have a complication. Remember this take home message. Either you have a complication like OSA in this scenario, or you have association like polyglandular syndrome, or you have underlying or different underlying cause like postpartum thyroiditis, particularly if you have a female in childbearing age. Okay? Thyroid is an easy case to examine, to take history, either hyper or hypo. But what will be the trick? You have to know it before leaving the station. I hope it's clear for all. And thank you, Dr. Marwa, for stressing on this point, because even if the case will be smooth, the examiner might be tough in the questions. Why? Because you have easy case. So you have to know the all things related to the case, plus the examination steps. You have to cover the all examination steps without missing any part. The eye examination in the gravis, for example. If you miss the eye examination in the gravis, they will minus you 100%. The thyroid examination, of course, you have to do it. But what you might miss the eye examination or the cardiac examination, for example, for AF. So the association always will be something essential to pick up, either in the history or in the examination. This is the take home message. Please don't underestimate your case or to say, oh, it was very easy case. No, it will not be easy. If it is easy, there is something will be hidden. Okay. If you are ready, Dr. Hisham, we
Uh,
can ask.
hi,
Start. Anyone has question? Yes.
Hi, Dr. Basim. I just have one question for the differential diagnosis. Just to recap, The first differential would be hypothyroidism complicated by obstructive sleep apnea. The second differential, so hypothyroidism, I mean, mostly autoimmune, complicated by OSA. The second differential will be other differential for tiredness, or because obviously there is no other like differential diagnosis or possible cause for the hypothyroidism. It's not
Okay,
possible not decurving.
okay, good question. So you can ask the examiner what you
Mm.
want me to give as a differential. You want to give a differential diagnosis of hypothyroidism. Now you can enumerate the all cause of hypothyroidism. Or you want me to tell you what can be a differential for fatigue with hypothyroidism. Then you can give him the cause of fatigue with weight gain, for example, not with hypothyroidism, because you don't know the case is hypothyroidism.
Mm.
So what are the cause of fatigue you want me to enumerate? Yes, please, doctor. So you will say with the weight gain, I will put on my differential hypothyroidism, as in our case. What else, doctor? Polycystic ovarian. Or what else, doctor? Cushing, right? All of them can cause can cause fatigue. Or if he ask you, doctor, give me the cause or the possible cause of hypothyroidism. Now you can give the all cause of hypothyroidism.
Okay, just from your own
Yes.
experience,
Yeah.
do they usually ask about the differential diagnosis for the presenting complaint, or do they ask the differential diagnosis for the like definitive case? I mean, the first differential in the case.
If there is debate, you have to ask. It's not
Mm.
related to the complaint only or the diagnosis only. But you
Okay.
can ask and be sure that he will help you and he will guide you in the differential. Okay?
Mm.
But you're right. Sometimes they need the differential of the complaint.
Yeah, because it's a bit vague. For example, when you just start the case, you put in your mind a differential diagnosis for tiredness or fatigue, and then when you just go over the case and you pick up
Yes.
the hypothyroidism, then you just make a new differential diagnosis for the hypothyroidism itself.
Yes.
So,
In case if you have such scenario, ask the examiner before answering him. Why? Because he will judge on your answer of the differential. He might
mm,
accept. He might accept to give this or that, either the differential of the diagnosis or differential of the complaint. Okay, but I believe the most relevant answer will be related to the diagnosis, not to the complaint. Okay, because you got now the hypothesis. You will give the causes or the differential of hypothyroidism in such age. So you can give the causes as I mentioned. You can add also not only the hypothyroidism with association like polyglandular. Can you put it here? Yes, I can say this is the differential, one of the differential. So thyroid with fatigue and hypothyroidism, I can put polyglandular in such age. You
mm,
can say also with that there is family history of diabetes and thyroid. Okay,
mm, okay, yeah,
so to be safe and to have good mark and to stop this debate, ask the examiner what differential exactly you want. Is it to the complaint or to the diagnosis?
okay,
Okay,
yeah,
but
I,
yes,
I think that I just wanted to add on that because complaint at times could be quite vague, as you said, fatigue, and similarly I keep on saying fatigue, fever, vomiting. I mean, these are the common kind of symptoms which can have a number of differentials. I mean, a lot of
exactly.
lot of systems could be affected by these
Yeah.
complaints. So it all depends that what exactly is your clinical judgment based on the history and examination, that which way this patient is going in terms of the differential diagnosis. So I think in that case, in the current one, I think if you say hypothyroidism with obstructive sleep apnea, that's fine. Then you can say, I would like to rule out a possibility of a autoimmune polyglandular because the anemia could be related to pernicious anemia. Thirdly, I would also like to rule out a possibility of a polycystic, although it might not be. I mean, some of the things might not be linked, but in differentials, basically that the theme is that you put up what you think is most likely, and then what else could possibly be, because you haven't investigated the patient, and you know that being all of us being clinicians, that
yeah,
a lot of time our topmost differential based on the history and clinical examination might not be the final diagnosis based on the investigation. So history examination, what is the most likely diagnosis, and what are the other possibilities, which obviously will help you in making a plan of investigation. Just that you go in that line, because fatigue, fever, as said, that these are very general symptoms, and if you start giving differentials based on fatigue or fever, so it may comes out to be 100 differential diagnosis. So
Exactly. Yes.
generally
Yeah.
it's the history and examination which will lead you to the clinical judgment, and then you can organize your investigation plan as per your differential diagnosis list. Yeah.
Yeah,
Exactly.
I think that makes sense because
Yeah.
when you put a differential diagnosis for your presenting complaint, you can just see that these differential diagnoses will be dropping out when you're taking history and examination. And this is the case for the tiredness for today. When I just put the differential diagnosis, by the end of the examination, I would like to include all these differential diagnoses except the hypothyroidism. So I think that makes sense. It should be collectively taken from the history and examination, and then
Yes, you're
include.
right. Particularly, Dr. Ahad, if you have, for example, thyroid swelling or goiter, you cannot say this is could be Cushing, or I can give differential of
Yeah,
fatigue. Here,
definitely.
I should put differential with something including thyroid or hypothyroidism. Okay.
Yeah, yeah.
Yes, you're right. Thank you, Doctor.
Sorry, just
Yeah,
one comment for
yeah,
I think I don't know the name of the doctor who.
Dr. Muhammad. Yes.
Sorry, Dr. Mohammed. Just for I don't know if you included the psychological support for this patient in the management or no. But I think this is an important point, as the patient mentioned that he has like what's look like a depression or mood changes.
Hmm.
So it's
Yes.
a very
Yeah.
good point
I
to
think, yeah, I think that I agree, but that's what I mentioned in my uh,
Yeah.
feedback as well, that
you mentioned that
he
as well.
didn't actually ask about the mood changes. So that's why he didn't go that route. But this patient obviously had these mood changes. She was worried about a possibility of losing the job. She was depressed as well. So she
Yeah,
definitely needed the support as well. But because as he didn't ask in the
Yeah.
history, so I think that's why he didn't go that route. But I agree with you that
Yes.
this patient definitely needs support in that regard as well.
Yes.
yeah. I think in any case of hypothyroidism, it should be asked in mood changes because it's a very prominent symptoms. And
Yeah.
once the patient have mentioned, because I think Dr. Ihtisham mentioned that he's having mood changes and he's not like able to just resume his work. So I think psychological support is very important point in the management. This is the first thing. The second thing about the driving, you've asked about the driving at the end, but when you just ask, I think it's two-way, just to be reasonable to the patient. Either to just defer the advice of stopping the driving until the end with the management, or if you would like to mention it in the beginning, because when you just mentioned to the patient that you should stop driving, the patient asks you, why should I stop driving? And I think this should maybe affect the judgment in some way. So if you can just tell the patient that if you would like to mention it early, so if you can just tell the patient that I will advise you to just stop driving, and I will explain more about this, okay, later.
Yes.
Um,
Yeah, this and the good advice. Whenever you have an issue to advise, start or do it immediately. Otherwise, you might forget it. But here,
yeah,
Dr. Muhammad, remember at the end. But you don't know in the exam, or maybe with the stress, you will tell him, "Okay, I will answer this question later on." Then later on, either no time or you forget it. So the best way do it on the time. Yeah, thank you, Dr. I had good comment and advice. The mood, always we are forgetting the mood. And CNS complaint, please remember the mood and sleep and mood. And SMS, I always say. So sleep, mood, and what the third is sleep and mood. I cannot recall it now, but always remember to ask about the sleep and the mood whenever you have CNS patient or you have some complaint related to the constitutional symptoms, because the fatigue, the fever, all the things might lead to low mood or depression. Okay, let's start, Dr. Hisham, if you're ready.
Yes, please.
Yes, here you go.
Hello, hi. My name is Dr. Khader. I'm one of the doctor here. May I confirm your name and age, please?
Yes, I am Nadia, 48 years.
Nice to see you, Nadia. Nadia, I understand that you have got some problem like vomiting, and I will ask you further details about your problem, and I will after that I will examine you as well. This will all be confidential. Is that okay with you?
Yes, doctor.
All right. If you can just tell me that for how long you have been problem with vomiting.
Yes, doctor. Since 1 month, I have this vomiting 1, 2, 3 times per day, and it's
Mm-hmm.
not moving. I don't know what's going on.
Right, right. I'm sorry to hear about that. So we'll definitely explore it further and then we'll guide you on that. So you said that it has been going on for the last 1 month. If you can just tell me that, is it something which happened anytime or there's any specific time of that?
No, anytime can happen, doctor.
Right, right. And what exactly are the contents of that vomitus?
Sometime it happened after my food by 1 hour.
Mm-hmm.
Sometime no relation. Sometime some greenish material coming.
Right, right. Have you ever noticed any blood in that vomitus or any
No, no,
kind of
doctor.
a coffee ground kind of a vomitus?
No.
Right, right. Okay. And have you noticed any problem with your bowels?
Actually, at night sometime I have some loose motion, but not too much.
That's also been happening for the last 1 month?
Yes, it happened before, even not this month only. It happened before.
Right, right. Okay. And you said that you had loose motion off and on for the last 1 month. So generally, how many episodes of loose stool you have
Not
in
much,
a
sometime 1 or 2 times at night. Not
Mhm.
too.
Is it just watery stools?
Some soft, some loose, not watery.
Mm. And have you noticed any blood in that?
No,
Right, right. Okay. Have you got any pain in your tummy?
not pain, but I feel not comfortable.
So is it any specific area where you feel uncomfortable or is something which
No,
is all over?
all over my abdomen.
Lower abdomen, okay. And after passing the stool, do you feel that there's any improvement in your discomfort?
Yes.
Right, right, okay. Have you noticed any yellowish discoloration of your eyes?
No.
hmm Right. And any distension of your tummy? Or you feel that your tummy is more swollen?
Is this discomfort, doctor? Maybe some distension. I don't know.
Right, 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 okay. And have you got any problem in swallowing?
No.
All right, okay. And in the last 1 month since you have these symptoms, have you noticed any weight changes?
Yes, doctor. I feel my clothes become loose, but I didn't measure my weight.
Right, right, okay. But you feel that you have lost some weight as well. All right, okay. So apart from that, have you noticed any temperature, raised body temperatures,
No.
any tiredness?
Yes, doctor, 1 month I am vomiting. I am very fatigued.
All right, I'm sorry to hear about that. We'll definitely try to sort that out. Uh, so you said that you don't have any high body temperature. So apart from that, any problem with your sleep?
No, my sleep is okay. Only
Mhm.
for that some loose motion. I wake up and become
Any?
good after giving.
Mhm. Right. And any lumps and bumps in your body?
No.
Right. You said that these stools basically they're more bothersome at night, the loose stools.
Yes. But not too
hmm
much, doctor. Only 1 time, 2 time. I have this since time. Not, it is not new for me.
Yeah. For how long you have this problem, if I ask you that way? I
Year,
mean,
2 years.
sorry?
Maybe 1 year, 2 years. I don't
Uh-huh.
remember.
All right. Okay. But the vomiting is a new
That
one.
it's not bothering me too much. I am bothering for that vomiting.
Right. Okay. Right. And other than that, have you noticed any change in your skin color?
My skin color,
hmm
I don't know, doctor. I didn't notice really.
All right, okay. And have you got any similar problem in the past as well?
Regarding vomiting, no.
And regarding these loose stools, you mentioned that you have
Yes,
been getting
doctor,
these
I
for the
told
last.
you I have
Hmm.
this.
Hmm. And have you been diagnosed with any other medical problem?
Yes, I am diabetic and hypertensive.
For how long you have diabetes?
Maybe 6 years now or 7 years.
Hmm. And have you been on any medications for that?
Yes, I have metformin, glycoside.
Right, right, right. Okay. And how is the control of your diabetes generally?
I am not good patient. I am not يعني maybe every 6 months I'm going to
Hmm.
the.
And have you been regular on your medications?
Yes, I am following it well.
And when was the last time you had that blood test done for, or do you monitor your blood glucose regularly?
Last 3 months it was 8.5.
And when was that? The last time you had that check?
3 months back.
All right, okay. Right. And what medication you have been taking for your high blood pressure?
Valsartan.
All right, okay. Right. Apart from the diabetes and hypertension, anything else which is in your past history?
No,
Any operations?
no.
All right, okay. Now I'll ask you just a few general questions. Have you noticed any dizziness when you are standing up from a sitting position?
Yes, doctor, I have the dizziness. Maybe last week started with me.
Uh-huh. Okay. So what exactly happened? If you can just tell me a little bit more as well.
What again, doctor, please?
So what exactly you have been experiencing? So what happened? You said that you feel a little bit dizzy. So what happened exactly? When you, I mean, is it something which only happens when you stand up from a sitting position, or is
Yes.
it something which happens any time and without any positional changes?
So this week I started to have when I stand suddenly from my sitting position, I feel little bit dizzy. I sit again, I become okay.
Right. Okay. And have you noticed any breathing difficulties?
No,
Any pain in your chest?
no.
All right. Okay. Have you noticed any headaches?
I have my stress in work. This maybe sometime I take some Panadol, a light headache
Where exactly is that?
over my head. And this since a long time. This is not new for me.
All right. Okay. All right. And may I ask you a few further personal questions? Do you smoke
No,
and do you drink alcohol?
yes, light
How
during
how many
weekend.
how many units a day generally?
At weekend.
All right. Okay. So you're within the limits.
Yes.
Have there been any recent change in your diet?
No,
And have you recently traveled anywhere?
no.
Right. Okay. Uh, if I just ask you a few more things, that have you noticed any problem, any weakness in your body, or anything like problem sitting up from a standing position?
No.
All right. I'll keep asking you some question, and meanwhile, I'll start examining you. Is that okay?
Okay, doctor.
All right. Okay. So I'll start just with the vital signs. I'll check the patient's pulse, the blood pressure.
Pulse is 85.
Hmm.
Blood pressure 140 over 80.
I'll also look for the postural drop as well.
Yes, there is 20 millimercury drop.
All right, okay. I'll just look into the skin if the skin is dry, or is it any abnormality of the skin.
You mean skin turgor or what?
Yeah, any skin changes, any skin rash, any dryness of the skin, or any.
Rashes.
I mean,
That looks too dry.
all right, okay, all right, okay. Then I would also, after that, I would like to examine the abdomen. On I'll first inspect the abdomen to see if there's any distension of the abdomen. Is it moving normally? Then I'll palpate if I any appreciate any tenderness, any visceromegaly, and after that I'll percuss and do the auscultation as well. So if there's any positive finding on the examination of the abdomen.
Distension, no shifting dullness, some abdominal discomfort when you press in the deep palpation.
All right. So it's only abdominal, some discomfort without any other positive signs.
Yes.
All right, okay. After that, I would also like to examine, uh, yeah, so I would also like to examine if there's any evidence of swelling in the neck, and I would also like to complete all the steps related to the thyroid examination as well.
Thyroid is okay.
All right, okay. I just wanted to ask you, have you got any other family history of note?
I think my mother have also diabetes, doctor.
Right, okay. And apart from that, any other cancers in your family?
No.
Right, okay. I will also like to examine the heart of this patient just to look for any the heart sounds and if I can appreciate any added sound. And
182 is okay. No adventitial sound, no gallop.
all right, okay. I will just look quickly and screen if there is any abnormality on the examination of the eye movements.
Eye movement? No, it is okay.
All right, okay. And after that, I would like to examine the oral cavity for any problem with the tongue, any signs, any stomatitis or glossitis, or yeah, generally the oral hygiene as well, and any oral ulcers.
No, it's okay.
And I would also like to comment and see the skin color as well.
Skin color? Only
Mhm.
dryness. No, no other
Mhm.
abnormal.
Right. Okay. And may I know that, Miss Nadia, what kind of job you are doing?
I'm accountant.
All right, okay. And I just wanted to, are you getting your periods regularly?
My period is okay, doctor.
All right. And have you been on any pills, like
No,
a hormonal pills? All right.
no,
And have you had any pregnancies? Are you married? Sorry.
no, I am not married.
All right, okay. And have you had any partners in the past?
Yes, I have partner.
Uh-huh. And have you ever been pregnant in the past?
No,
Right, okay. And any miscarriages?
no.
All right, okay. Do you get any numbness and tingling in your feet and in your hands?
Yes, I have in my feet, yes.
Mm-hmm. All right, okay. I would also like to examine the reflexes and also like to check for signs of peripheral neuropathy in this patient. Uh, Miss
There is some
Nadia.
appearance, peripheral neuropathy.
All right. And also like to offer fundoscopy to look for any changes of diabetic and hypertensive retinopathy.
Non-proliferative, non-proliferative retinopathy.
All right. Okay. Uh, the one thing which I just wanted to ask, so you said that you're working as an accountant, how this is affecting your job?
2 minutes left.
Yes, doctor, I have this vomiting, make me too much sick leave I am taking. They will fire me from.
Hmm. No, I understand. I'll definitely sit and will definitely help you in that, and will have support available in that regard as well. Have you
Thank you.
got any problem with your waterworks?
Increased nowadays.
Any frothy urine or any blood in the urine?
No.
All right, okay. And right, so Miss Nadia, may I know that what exactly are your concerns?
Doctor, what's happening with me? I need to know. It is serious?
Right, okay. I fully appreciate your concern, Miss Nadia. I think that there have been few possibilities which could lead to similar kind of symptoms. I and we need to further investigate that what exactly is going on. The things which I feel could potentially be responsible, it could just be due to your diabetes, that you may be having all these symptoms. It kind of a complicated diabetes. The other possibility is that you might have some other problem, something like another problem with your glands, which could affect potentially and cause these vomitings and sometimes problem with the stool. And yeah, so I think that we need to find out that what exactly is going on. Obviously, there are few possibilities, and we need to find out that what exactly is the reason for that. Any other concerns?
I have some sweating and with this dizziness. I have some sweating and I don't know what's going on. And
Sorry?
maybe one day I measure my heart glucose at this time, it was very low. Does it matter my work, affect my work or affect anything?
Sorry, you what exactly you're saying? I think that your connection was lost. So what exactly you're saying? You said sweating?
With this dizziness, doctor, yes, I have some sweating and some pain in my abdomen.
Mm-hmm.
I
And you
measure
said that.
my
Uh-huh.
RBS at the time, my glucose, it was low.
How low was that?
I think less than 70 milligram.
All right, okay. As I said that basically you are thinking on a possibility of a complicated diabetes. So sometime when you have diabetes, you might have affected multiple organ system, and one of them is your nerve. So there is a possibility that one of the nerves in your body that might be affected. There is a system in medical term which we call autonomic nerve. So it's a kind of a nerve which can be affected, and that can cause all kind of the problem, like the problem with the vomiting and the problem with the stool, and also the one you were saying that you do experience these sweating. So sometime that could potentially, and sometime when you have a complicated diabetes, you might have difficulty in uh, I mean, sometime you might not be able to assess that you are very low in your sugar, and that could lead to potentially dangerously low blood glucose as well. So that could be a possibility. So that's what I'm saying, that we need to investigate it further, that what exactly is going on. Any other concern, Miss Nadia?
You, thank you, doctor. Thank you.
All right, okay, thank
Okay,
you very.
examiner questions.
Yes, doctor, give me the positive finding.
Right. Okay. So I think this 48 years old lady, she came in with a history of vomiting for the last 1 month, along with problem with with some loose stool, primarily at night time. She also mentioned some sweating and found to have a low blood glucose at at that time. In the past, she had a history of diabetes and hypertension, and seemed that diabetes is not very well controlled, and the last HbA1c was about 8.5 as well. There doesn't seems to be any changes related to the diet, or not no recent travel as well, and there is no similar history of any such episode of in the past as well. On examination, I could appreciate that she has a significant postural hypotension as well. Apart from that, there was only some abdominal tenderness. The rest of the examination also revealed that she had changes of diabetic retinopathy, and also uh, there were feature of peripheral neuropathy. So in all, I think that this lady has a very complicated diabetes mellitus, and her symptoms could be related to autonomic neuropathy. This is one of my differential diagnoses. And yeah, and other thing which I would like to rule out in her case is a possibility of Addison disease. The thing which is against that, in my opinion, is the blood pressure at the moment is okay, and she doesn't seems to have any changes of skin related to the Addison disease as well. So the only thing is that a significant postural hypotension. So that, yeah. So I think that these are the things which I would like to. The other, thirdly, I would also like to. Sh I didn't ask, but she herself didn't mention any symptoms being related to any kind of food. She just mentioned that it can happen anytime. But also in this case, I would also like to rule out a possibility of a celiac disease. And at her age, I would also like to rule out or screen her for a possibility of inflammatory bowel disease. She seems to have a significant weight loss, which could potentially be due to the symptoms which she has been experiencing. But I think that we need to investigate her further to find out that what exactly is the reason for all the problems.
Okay, doctor. So give me enumerate the differential by the most probably and the least probably.
Yeah, I think that the, I would consider that it could just be autonomic neuropathy, most likely related to diabetes. That would be one thing I would like to rule out. The second thing, I would like to rule out a possibility of a celiac disease. Thirdly, I would also like to rule out a possibility of inflammatory bowel disease. However, uh, the symptoms that doesn't seem very classical. Her weight loss is quite significant, so I would also like to rule out the possibility of an underlying malignancy as well in her case, in her age group as well. Yeah, so I think these are the few differentials I would like to work on and rule out these possibilities.
Okay, doctor. What is your management plan?
Yeah,
Started from investigation.
yeah, yeah. I think that this lady has a very significant postural drop and she has a significant vomiting for quite some time. She's at a risk of fall, so I would like to admit this lady in the hospital initially to investigate her further, because just to minimize any risk of having a fall as well in this lady. After that, I would like to have a multidisciplinary team approach. So in terms of the investigation, I would start with doing some simple blood work, starting with a complete blood count, the inflammatory markers like CRP and ESR. I would also like to do UNEs. I would also like to send a stool sample in this lady. I would like to consider doing another HbA1c and also look for any uh, the the blood glucose while she's in the hospital as well. These are the initial investigation I would like to see. If I find any abnormality which might suggest that the cause of vomiting could possibly be due to the Addison, I would like to screen for that and do a 9 a.m. cortisol level as well. The other investigation will depend all upon the initial, and I also like to do a thyroid function test as well in this lady. The second set of investigation would be uh, based on what exactly I find on my initial investigation. So it could potentially be including uh, an upper GI endoscopy or a colonoscopy if there are signs in the initial investigation that this could potentially be in that way. Before going for those invasive investigation, I would also like to screen her for celiac disease as well, considering her age and the symptoms. So I think that I would like to do the antibodies for the celiac, the anti-TTG, the anti-endomysial antibodies as well, to screen for the celiac disease. So I think these would be my line of investigation initially.
Okay. For your treatment,
Yeah. So as I said, that it would be multidisciplinary. So I would like to admit the patient. I would also like to uh, take opinion from the diabetic or the endocrinology team to advise on the better management of the diabetes. In terms of the general management, I think that this lady, we need to see that what exactly is the diet and what are the reasons that why the diabetes is not in uncontrolled. We need to escalate on the treatment. We need to have a diet plan for her to control her diabetes and hypertension in a better way. She will also require some support from the physiotherapy as well, and even the occupational therapy, because um, she has a significant postural drop. So we need to assess that whether how much is the risk if she is at home, and a risk of fall, because if she has such a significant dizziness, so obviously she need to be assessed for that. I didn't address one thing, but I think that she would be a little bit at risk of driving as well. So till the point we investigate her further, I think that I should have advised her to stop driving till we sort that out. Then the other management point, as I said, that it will all depend upon the investigation and the final diagnosis. We need to involve a gastro team as well to look into these symptoms, the endocrinology team as well to look for a possible autonomic symptom. And yeah, so I think that she needs to be admitted for further evaluation, and then we can formulate a plan accordingly. And also we need to ask whether if she require any kind of support, because she's working as an accountant, so we need to offer support in that regard as well, whether because while she will be admitted and she will be off sick, so we need to arrange for the sick leaves and also offer social support. One thing I didn't ask, obviously because of the shortage of time, was that I didn't ask that if there's anyone, I mean, if she is supporting someone at the family as well, because in that case, we definitely need to arrange for some support as long as she's in the hospital and till the time she's back to work as well. So it will be a collective multidisciplinary approach to address all these concerns and to formulate a proper management plan.
thank you.
Okay. Thank you, Dr. Hisham and Dr. Muhammad. You can comment now, Dr. Muhammad, please.
Comment first, just to not forget, you will not have, Dr. Hisham, you will not have all this time. You should be very more faster than this.
Sure.
The differential and investigation, the treatment, everyone you have 1 minute. So
Or
target it. Don't give a chance to the examiner to still ask you, give me again, and then you meet me again. This you will miss one of the at the end of the
right. Yeah.
document. Okay?
Right.
So
Right.
be more targeted. This is my first.
Sure. Thank
Regarding,
you.
start from the history. MashaAllah, you take it very good, really, from the relevant complaint and relevant system. You catch it. طبعا it is looks a classic, but it is not. طبعا usually, if you, as Dr. Basim mentioned, if come classic, it will be a tricky, and you should be very careful for every step you will give during your explaining and management like this.
Right.
From the beginning, you take a little time more in the complaint and relevant system. But when you reach the family, the past medical history, خلاص you catch this is complicated diabetes, patient not compliant. Mostly it will be related to endocrinology and mainly diabetes and its association. You to take it the complaint and the relevant system, then you go, I think, to the constitutional, then you go to other the past medical, then the systematic. Uh, but when you reach that it is complicated diabetes with its association, you didn't يعني stress on the association of autoimmune. Like when I mentioned this, I have some loose motion. You didn't mention if it is related to some specific food and like this. So خلاص to rule out
Mm.
it is celiac or not. You didn't tell me any weather preferences to, I think, and as I remember, to rule out the hypothyroid. Addisonian, you catch it, but it is not one. I confirmed that it is just 1 week, and this mean he has severe dehydration. He don't have from the beginning, so he don't have Addisonian from the beginning. He has it 1 week back only, يعني more than 3 weeks after having frequent vomiting. So you asked also about the yellowish of the eye, this to the autoimmune hepatitis, or also related to autoimmune. So يعني the association is very important during taking this history. But when you mention the management, you have many signs this patient is sick. Blood pressure dropping more than 20. This patient is very risky. And the patient skin, I mentioned many times, patient is dry. And the patient continues vomiting and increasing the vomiting. When you mention the management, your management will be very aggressive at the beginning. I will admit the patient, I am afraid he has acute kidney injury after all this vomiting. I will admit him, I will admit urgent EPG and electrolytes, maybe need dialysis, I don't know. Even if you have more urine, it is maybe a late stage of the acute kidney injury. So this is regarding the يعني to make the examiner impressed that you catch this is a critical case. It is not a normal case that one month he's vomiting and you didn't ask him how he's compensating for this vomiting. So firstly, rule out the acute kidney injury, and maybe he has uremic symptoms. Maybe after he has some problem at the beginning, then become complicated by acute kidney and uremic, and become uremic symptoms, increasing his problem. Regarding the examination, you did it very well. You pass the eye first, تمام? And this missed from me really يعني, about the eye. You measure. I mentioned for you headache. It was tension headache, but in such cases, very important question. If it is if during it's happening in the morning and increasing this headache increasing with leaning forward, or يعني to rule out any space occupying lesion. This is very important. And during examination, you will measure also with movement, vision field also. It is very important to rule out these space occupying lesions. Um, Again, examination, you reached thyroid. I don't remember you mentioned lymph node or not. So important also. We suspect malignancy, space occupying lesion, must be lymph node examined. Go to the heart, right? You examine it. The abdomen, yes, you examine it. Good. Sensory, yes, you examine that, you confirm that it has diabetic nephropathy, has the diabetic retinopathy by fundus examination. Also, during the history, once he told you that I have diabetes and such, this uncompliant patient and 48 years old, you have any heart attack before, you have any clot before anywhere, to rule out this very important complication from the uncompliant diabetic patient. This will help tell the examiner that you are following what's happening before to him, and what maybe give you some hint about his new problem. Regarding the diagnosis, you mentioned to the patient maybe related to diabetes and affecting your nerve, but you didn't mention to her what is this. It is called gastroparesis. The main issue or the main diagnosis for autonomic neuropathy and gastroparesis. This causes for many vomiting. Even her loose motion at night, it is related to autonomic neuropathy. It is nocturnal diarrhea with autonomic neuropathy. That's why I confirmed many times. It is not too much. I have it since a long time, and I accommodate for it. So first diagnosis, you will tell my first diagnosis gastroparesis, right, as a diabetic autonomic neuropathy, but at the same moment you tell him, because of it's the patient's significant loss of weight, I need to do urgent OGD for the patient to rule out any cancer or any sinister peptic ulcer. This is very important also. Yani both the same gastroparesis, yes, by the history, but I need to rule out the cancer stomach as very in view of her loss of significant loss of weight. After that, acute kidney injury, uremic symptoms. I need to rule out other association with the patient. As you mentioned, I need to rule out celiac, Addisonian, hypothyroid. Tell them the three, because this is significant autoimmune, this significant diabetic complication and has past family history. No clear history in front of you to rule out all other association. You don't know this is positional hypotension from her dehydration, or already she is Addisonian, despite there is no pigmentation. But the third line you will tell, I need to rule out the other association by screening labs for the hypothyroid, Addisonian, and celiac disease. The mentor, when I take this case, mention that avoid to mention autoimmune polyglandular, because this patient usually the polyglandular type 1 on insulin since a long time. It's not, he mentioned metformin. So no need to mention this. You can mention drug induced by metformin, sometimes cause some distension and some abdominal problem, especially if she just increase the dose or new start for metformin. This is the four things. Regarding the investigation, as we mentioned, the emergency will admit and do the first priority for us, the life-saving or life-threatening condition. Then to rule out in life-threatening condition. Then to confirm our diagnosis, we told طبعا the emergency OGD and acute kidney injury management. Then to confirm my diagnosis, which is my first diagnosed gastroparesis, you didn't mention any motility test or gastric emptying test or يعني في many things capsule test, في many things for it, but at least you can tell I need to do one of the gastric emptying test to confirm my diagnosis. Then to the screen, as we mentioned, screen of other association, celiac antibodies, Addisonian serum cortisone 24 hours or short synectine, and that celiac antibodies as you mentioned. You can also add ultrasound abdomen, CT abdomen, if not, if still the OGD not done. The other risk factors in your routine lab, the other risk factors for clots, hemoglobin A1C, lipid profile, and yes, this is sometime he may need for review regarding this headache. If you can also add MRI if you the history gives you some impression that there is space occupying. Very important also to mention, I need also to rule out pregnancy. I will do one screen for pregnancy test. Any female, even she told you period partner, because hyperemesis gravidarum is very important in such case. طبعا regarding the welfare, you delay too much the asking about the hypoglycemia, and despite she mentioned for you I have dizziness and I take many sick leave. You didn't mention driving except the last moment in the case. And it's very important, me minus you, despite all this. Alcohol also very important. You should advise here. We can plan for stopping it because it's affecting your condition. It's one of the causes for autonomic neuropathy. Okay, Dr. Basim, Dr. Sam, but generally you did very well. But my comment only be more fast and more in the discussion with the examiner, and me more lines, and he will forgive you for the missed thing when you feel you that you didn't miss the major thing. Okay, multidisciplinary team, as you mentioned, all support for the patient, all the team to be there. Okay.
Yes, thank you, Dr. Muhammad. Good comment. Good case as well. Yeah, it's a little bit complicated and a lengthy one. But what the trick in this scenario, as Dr. Muhammad said, the diabetes. That's why we always and usually ask about the past medical history after the constitutional symptoms. Why? Because the case might be there. The diagnosis, I mean, might be there. Here, once you have a diabetic patient, particularly for a long time, or type 1 diabetes, be sure the possible differential or maybe the top differential might be related to diabetes. As in this scenario, autonomic neuropathy, autonomic neuropathy or gastropathy related to the uncontrolled diabetes, or metformin itself, whatever the underlying, but still, I have to suspect the cause related to diabetes. What Dr. Hisham missed in this scenario, and I think he might miss the case because of this question or this questionnaire. Whenever you have diabetes, Dr. Hisham, start to ask about, as you said, is it well controlled? How is the follow up? So the control, the follow up, the diet, the exercise, and the last, hemoglobin A1C. This is regarding the diabetes once you discover this is diabetic patient. Plus any hypoglycemia. We always ask about the hyper, but we never or sometimes we are missing the hypoglycemia. Is it important? Yes, it's important. One of the welfare point, the hypoglycemia. You might even remember the driving, as Dr. Muhammad said. So you might miss the driving, you might miss the case if you didn't ask about any low blood sugar previously or before. He will tell you yes or no. According to his answer, you can address on time, either to control or not to be having this hypoglycemia or to refer him to the diabetic doctor immediately. What else in the systemic review? The stroke, mini stroke, the complication, macro and micro complication. You didn't ask about any stroke, mini stroke, any heart attack, any neuropathy, any nephropathy, any peripheral neuropathy, any nephropathy. Yeah, it will be included in the systemic review questions. Either direct as stroke or mini stroke, heart attack, these are as direct question. Or the kidney itself, you can ask about the frothiness, the vision, and the peripheral neuropathy as numbness or tingling. Be sure there is or it would be there as a complication, particularly the poorly diabetic control patient. What other important here, as Dr. Muhammad mentioned, the acute setting. Patient is presenting with vomiting frequently, increase in the frequency nowadays, the content. The analysis was good, even more than good. You analyze more than enough. As Dr. Muhammad said, yeah, you spend a lot of time to ask about the relevant system, the GI, and the vomiting itself. But I'm wondering why you didn't ask about the loose motion related to the food. You ask, did you ask this question, Dr. Hisham? I'm not really remembering. Can you confirm for me?
No, no, I just asked about the loose stools, and I
Yes.
asked, yeah, no, I didn't ask about the
Yeah.
diet relation.
And you mentioned celiac. How you mentioned celiac without asking this question? It's a very
Mm.
important question. You cannot put the celiac as a differential, and at the same time you cannot roll it out. The most important question to say this is celiac, you have to ask about relation to food. You are saying, kept saying differential celiac disease. How about the relation to the food? One question only can know this is celiac or no. The other diarrhea question you have to analyze the amount, the related to the meal, any blood on it, in it, and is it watery, flushable? All this question to rule or to conclude this is related to celiac or malabsorption or no. So it's important to know how to analyze. The same comment when you give to Dr. Muhammad, he didn't analyze the headache. Here you didn't analyze the diarrhea. Usually we are analyzing the complaint well. But in between, whenever you have positive finding, we are not analyzing them. We are skipping, or we are underestimating, or we are not giving more time to analyze them. Why? Because we are hurried. We are in hurry to finish the discussion or to know the other finding. No, it's wrong. Totally wrong. Whenever you have something positive, analyze it immediately as you are taking complaint. It might be related to your case, and as in this scenario you might say this is gastropathy or metformin related, right? Or autonomic neuropathy, as we mentioned. Otherwise, the examination, yes, you have to say about the blood pressure, sitting, standing. It's very important to know is it compensated, the fluid status, the pre-renal azotemia might be there. For the welfare, patient should be compensated, admitted, and with good hydration. All these things you can put it. Hypoglycemia, once you know it, you have to think about Addison. Addison in PACES comes in the same presentation, vomiting and diarrhea, abdominal pain. Vomiting, diarrhea, abdominal pain. Then you will find patient hypoglycemic, you will find hyperpigmentation, sorry, in creases or in scars before, and the dizziness, of course, while standing from sitting position. I believe it's very important to roll out Addison in this scenario, particularly if it started recently or acutely. Okay. I think Dr. Muhammad covered the most important point here regarding the investigation, emptying study, and motility test. Yes. Then what are the? He didn't ask you how to manage the gastropathy, Dr. Hisham. I will ask you this question: how to manage the gastropathy?
Get this. Yes.
Right. I think that there will be advice on the diet as well of once we
Perfect. Yeah.
confirm the diagnosis, so there will be advice on the diet, so maybe you can
Perfect.
even involve the dietitian in that. Then there could be prokinetic drugs which could be used, which could potentially help as well. So, and a good control of diabetes in addition to these. So I think
Oh,
these are, I don't know about any other medications. So
I will tell you, not medication. What are the prokinetic? Let's talk about them. Then the last step,
yeah, I mean, the drug which increase the motility,
like
something like a domperidone or
perfect, and
eh,
the other prokinetic known
um,
medication.
I think it's metoclopramide or
Yes, yes, metoclopramide, and one more,
etopride and yeah,
erythromycin.
erythromycin. Sorry,
Okay,
erythromycin. Yeah.
yeah. Okay, what if this all these measures failed and the patient has good control diabetes, but still he has the gastric this motility?
Yeah, I think that as I said, that there has to be a dietary advice as well, that what should patient eat, when should the patient eat, and there should be
Okay,
no Yeah, so it
Okay,
kind.
if you want to cover this point, what you want to say to the patient regarding the dietitian or the diet control? He will
I
eat
think
a big meal or small
no,
meals
no,
with the
small,
snacks in
small,
between.
small. Yeah, it has to be small, frequent
Yeah,
meal, and
exactly.
not and even uh, nighttime heavy meals should be avoided as well, and
With the
also
snacks
the
in between. Yes.
yeah, yeah.
Okay, the last thing. What if it failed? What you will give or what you will as a procedure? Do you know any procedure can help?
I think that there is one. I don't know. I don't know it's fundoplication or not, but I think that there is something which thing.
Pacing, gastric pacing.
Yeah, yeah, gastric pacing. Sorry. Yeah,
Yes.
yeah.
Yes. Okay, these are the management, particularly for. But the good thing in this scenario, and when you answer, you didn't start the pharmacological. You mentioned other advices, and we will follow for to the dietitian. It will help to control, to regulate the diet and the meals as well. Okay, they, always remember to start with the non-pharmacological. Don't only remember the pharmacological. Okay, well done, Dr. Hisham. I think with the time you will time managed or you will manage your time well. Today you spend a lot of time in the analysis of the relevant, but you will be much better with a good practice every time. You have
Yeah.
any question, you and Dr.
Mm.
Muhammad?
Thank you, Dr. Mohammed.
Thank you, Dr. Bassett.
Thank you, Dr.
Thank you.
Perfect.
Okay. Anyone has other question or comment? Okay. Yes. Dr. Ayula wants
I
yes,
sorry. I think that
yes,
I just
yes,
wanted to add one comment. I think that like the previous case, I think this case was also sometime when we pick up the diagnosis, then we at time become overconfident and we start jumping up and down. So I think this was another case where there were a lot of kind of dangerous sign. I mean, if because again here the expectation from the examiner, because it was diabetes and it was a complicated diabetes, so examiners generally expect that the candidate should cover each and everything. But like in the previous case, when you have a endocrinal disorder, most of the time it's a multi-system disorder. So one thing
exactly.
which will be an issue with any kind of endocrinal disorder would be to complete the history steps, because like in diabetes, if you go up and down you'll find it can, I mean, lot of organ system complications, so you need to cover and ask questions about all these complications, then the medications. So again, you might be able to reach the diagnosis at the end, but it may not be in the best of way, if that makes sense. I mean, like you will maybe you will be missing things which the examiner expect. Like in this case, I tried to look into complication like retinopathy, nephropathy, but I didn't ask about anything like a vasculopathy, any strokes or all these things. So I think these are all important things, and this was again kind of a high risk, maybe a little bit easy when you pick up that okay, this is a diabetes and it's a complication of diabetes. But I think that most of the time, other cases, like if you find someone having rheumatoid, for example, or a scleroderma, so in that case you can just target those things. But in a endocrinal disorder, I think because of the fact that generally it's a multifactorial or multi-system involvement. So I think that it would be at time difficult unless and until you are very much trained and very pro in doing all these kind of things, that you do all the things in a proper way. So I think it definitely needs the endocrinal cases. I think they do need a lot of practice, and that's something which my observation is.
Yes, you're right. It's multifactorial. And not only that, whenever you have diabetes, you have to screen the things I mentioned, the point I mentioned. As Dr. Muhammad said, and I repeat it, whenever the case is classical, there is a trick. What is the trick here? You have to know. It's a poorly controlled diabetes. But why this happened, you have to know, and you have to stress on the complication associated, like dehydration and the frequent diarrhea. Cancer is very important to mention. I like when you ask about any family history, but I would like to ask about any family history of cancer, colon particularly, or cancer in the gut. Why? Because it's related to the cancer in the bowel. I mean, what the importance if you have, for example, family history of cancer? Is it important, Dr. Hisham? And what is the next question? If you have, yes, I have family history of cancer, colon.
Yeah, I
What
think that it would be important to ask, and I think that I
what you will
didn't
ask?
go straight. Yeah, so I think that I did ask about the family history of any disorder. So I think that if there's a family history of cancer, especially if there's a family history of colon cancer, then in that case we need to ask that at what age the family member develop the cancer, because that will be another red flag sign as well. Then obviously you know that there are certain syndromic presentation of the cancer as well, in which there could be kind of a multiple kind of cancers in the family as well. So the other family members might be having some other cancers like a endometrial cancer or some other cancer. So the cancer history, obviously I didn't ask straight, but that was my intent. I just wanted to ask and from the patient if there's any significant. I was a little bit in myself, I was little bit, you can say, reluctant in asking a direct question that if anyone having a cancer, because that could potentially have alarmed the patient that I might be thinking in terms of that line. So that's what, but I think that, I mean, that's another question from you as well, that if I should go and straightly ask about directly from the patient about a family history of cancer, or should
Perfect.
I be more kind
Yes.
of a diplomatic way? Yeah.
Yeah, it's very important. Why, or particularly the age? You mentioned the age. What do you think if you have a patient with family history of cancer colon in age less than 50, two successive generation and three relatives have the same? What do you call this criteria?
I think in that case, generally we look for that something like an adenomatous polyposis colon syndrome, and also
What is the criteria name? Do you know?
criteria for what?
You have three family members or relatives in two successive generation. One of them in the age less than 50, he had the cancer colon. Do you know the name of this criteria?
No, I don't know.
Yeah, it's Amsterdam criteria.
Right, right.
Yeah,
Amsterdam.
and yeah, and then you will have strong possibility to have a cancer in this. So you have to specify the question for cancer colon,
All
and
right.
you have to ask about the age of the family member who had the cancer and how many relatives he had the cancer colon. In this
Right,
time or at this time, you can say there is a strong history. You might have the cancer colon. Okay.
right, right.
Okay. Any other question you want to add or comment?
No, I think
Yeah, thank
that.
you. In general, you did well, Dr. Hisham, and
Thank
Dr.
you.
Muhammad as well.
Thank
Yeah,
you very
thank
much,
you.
Dr. Mohammed.
It's very nice
And
and informative session. The cases was or were very, very informative one and nice cases with diagnosis also very common topic. So I hope all got the benefit from this session. Anyone has comment or question?
Dr. Bassem,
Yes, Dr.
I will send the picture that was when he examined abdomen. I forget to send, okay?
Okay, it's okay. You will send here or the WhatsApp group? Okay. And let's go to the comments in the chat box. Dr. Zoom user Addison. Yes, perfect. Good to put it in the first. DKA. Yes, I agree to say it as abdominal pain or vomiting. Gastritis. GERD. Drug induced or GERD side effect would be drug, yes. Gastropathy, particularly metformin, okay? So metformin can cause all this GI upset. Gastropathy, gastroparesis, Dr. Ala or Dr. Ala, uncontrolled diabetes with gastropathy, autonomic dysfunction, Addison, polyglandular syndrome, polykinetic erythromycin. Yes, Dr. Ayulan. Correct. Thank you, Dr. Lamar. Can I ask what, Dr. Ahad, why you advised stop driving? I haven't picked up this because patient had hypoglycemia. So the patient, whenever he had hypoglycemia, he should stop driving, right? Dr.
Yeah, okay, understandable. I
yeah.
get that. I just related to the
Yeah.
vomiting and dizziness. Okay.
Yeah.
Yeah.
And he had one episode of hypoglycemia recently.
Okay, and we're not entitled to inform the DVLA about the hypoglycemia. It's just stop driving until the issue's been sorted out, isn't it?
If you have first attack or a second or recurrent, if first you can address it, then if recurrent, he has to inform, right?
Okay.
Okay, the photo Dr. Muhammad shared. Okay, Dr. Muhammad, what do you mean by this photo? You mean this is a gastropathy case? Did you join back, Dr. Muhammad? There is a photo. I don't know.
Yes, Dr. Bassem. I mean.
Okay, you mean this is a scar?
During the examination,
Okay.
this is the abdomen examination. Okay.
Okay, this is for the case, you mean? For
Yes,
our
yes.
narrative. Okay. It was late, but it's okay. I will share it to also to the session.
It was Dr. Bassem. It is not. يعني he did it as a extra for the session. يعني
Okay,
for the-
it's okay. No problem. So you might have this colonic distension, scars. I think there is multiple scars. There is also subcostal scar, maybe cholecystectomy.
Yes.
I can see. Yes. Okay. Thank you, Dr.
But
Muhammad, again.
you need to know this sign, Dr. Bassem.
Yes. Yeah, good also point here, Dr. Zoom user. Added
Dr.
insulin and injection site. Yes, it's important to know is there hypertrophy or hypertrophy?
Lipodystrophy.
Yeah, lipodystrophy. Yes, either atrophy or hypertrophy.
Yes. At this time, during the judgment, when you are education counseling about this to be educated and send it to a specialized nurse to teach him how to rotate the site of injection.
Yes, perfect.
The
It's one of the,
communication very important. Yes.
yes, it's one of the points you have to ask about the injection technique and the rotation and the changing the site. Perfect, Dr. Muhammad. One important point you have to add, as well as during the communication, if you have patient with poorly controlled either hyperglycemia or hypoglycemia, this complication might happen. So with atrophy, you might have hyperglycemia. Sorry, atrophy means the absorption will be higher and the patient will have hypoglycemia. If the opposite, the hypertrophy, the absorption will be low and the patient will have hyperglycemia. Okay, so either you have this or that. Yes, and slow insulin release, as you said, Dr. Lamar. Yes. So it depends on the dystrophy, either atrophy or hypertrophy. Okay, thank you, Dr. Muhammad. Anyone has other comment or question? Okay, we can end the session now. Thank you, Dr. Hisham and Dr. Muhammad. See you tomorrow, inshallah, with the communication day. Thank you, everyone, for the attendance and the participation.
Thank you very much. Thank you.
Thank you. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.